Following from Anjan, I'd like to welcome Dr. Noor Mohammed from Leeds, an interventional endoscopist. He's one of a select band who venture into the frontiers, the third space, somewhere I think no man or woman should venture at all. But you're going to tell us about this subject matter. Thank you.
Thank you very much, Mark, and thank you for Professor Sanders for the kind invite. So I'm going to talk about vacuum therapy in esophageal perforations and leaks. Sorry, bit of technical hitch. Yeah, oops, slides have moved. So there we are, that's my disclosure, nothing for this talk. So the treatment options we have for esophageal perforations across the UK, I won't be wrong if I say that through the scope clips are the mainstay in all our endoscopy units. Over the scope clips have come up a long way and they're being used in many of the centres. Endoscopic suturing, fibrin glue and the vicryl plugs are used very rarely. As you know, through the scope clips, there are a variety of the clips available in the market with varying degree of rotational technique, rotational ability, the size of the clip as well as the strength of their arms. The most importantly, when you're closing the perforations, you also need to think about the stem of the clip. The longer the stem, it becomes difficult for the subsequent clips to be placed. So Dr. Mbak can give you the slide on the left hand side, but I must say that the perforations are mine. So small perforations you can easily close with metal clips and they do a really good job. But it's really difficult if you have a bigger perforation like that post dilatation. It's really difficult to get those clips on. Fortunately, it worked in this case, but I don't think it works in every single case of esophageal perforation. Over the scope clips, yes, it works really well. Clunky to use, difficult access makes it even difficult for placement of these, but it does work. There are two. Padlock clip is the top one and the overscope clip is the bottom one. It works in cases. Historically, the perforations, esophageal perforations have been dealt with by stenting. They do work in majority of the cases, but there are failure rates of up to about 15 to 20%. And they do come with significant comorbidities and sometimes surgical interventions and re-interventions are needed. They do have problems like stent migration, mucosal erosions, bleeding, and particularly if it is incomplete sealing, then you have a problem. And the other important problem with the stents are because of the negative intrathoracic pressure, the gastric secretions are drawn into the cavity where you don't want that to be. And that probably is one of the causes where you have stent failures. And particularly then the cavity becomes overloaded with the bacterial contamination and sepsis is a major cause of the problems here. And then you have surgery or reoperation which carries really high mortality and morbidity. That leads us to something different which is endoscopic vacuum therapy. If you speak to the surgeons, they know about the vacuum therapy for a very long time. They've done this for open wounds for a very long time with very good success rate, because the way the vacuum therapy works, it suctions all the debris out of the cavity, allowing the vascularization, allowing the new granulation tissue formation, and finally approximation of the cavity and sealing the cavity. It works really well. So the first published case for the post-anastomotic lower GI leak was in 2007, and following that it was used in upper GI leaks as well. So since 2008, there have been number of small case series available for leak treatment with vacuum therapy, with a good success rate, I must say. And sponge is either placed within the cavity, and if the cavity is quite small, then you can place it in the lumen so that the suction effect still works. So how big is the problem? Anastomotic leak is pretty big, actually. If you look at even in the higher volume centers, it's about 10% of the cancer work, OGJ cancer work, leads to some form of leak. And smaller centers do report much higher complication rates. And also patients do have significant comorbidities with regards to the mediastinitis which they have following the leak. So it is quite big. So B. Braun came up with this ESO sponge, which comes in a full package where you have the sponge, the overtube, the pusher, and all the rest of it. But what it doesn't have is the external suction apparatus. So the technique is quite simple of placing this ESO sponge. So assess the cavity first endoscopically, just to make sure where the lumen is and where the cavity is. Bring the scope out, put the overtube onto the scope, go back in again and put the overtube, place the overtube into the cavity, and then bringing the scope out, pushing the sponge back in through the overtube into the cavity. And that is placed. Once it is placed, then you withdraw the overtube, confirm the placement back again with an endoscope. So with this story, I've told you 3 intubations for the patient. So you must be careful of the compliance of the patients. So once the sponge is in place, then the tube is rerouted through the nose, and then it is connected to the suction apparatus. So it's a slow process, and the one which requires multiple exchanges. So the sponge is not left more than 3 days at a time. Otherwise, it causes adhesions, and sponge fractures can happen. So on the left-hand side, so that's named as per week. So week 1, you can see there's a yellow stent which was placed surgically into the cavity. On week 2, there is less because of some debridement already happening. Week 3 it's better. Week 4 is you see the granulation tissue forming already. And then you can now pull the sponge back into the lumen, more as proximal as possible. And then finally on the week 8, the cavity is completely healed. It took 13 exchanges for this patient and 8 weeks of intense treatment for the cavity to heal completely. So it is important to know that it's a slow process, and you need to counsel the patients appropriately and carefully. So as you can see, there's a fantastic result on the right-hand side of the screen, where you can see that the water-soluble contrast, instead of going into the cavity, it is now going straight into the stomach. So most important considerations prior to EVT are patient selections. You need to understand that this is a long-drawn process. Sometimes it can lead to failures, but the patient tolerability of the procedure is quite important. You can get the patients from post-surgical wound dehiscence, post-surgical cancer operations, and it is also important to know what treatment they have had. Have they had radiotherapy before? Have they had any other treatment, the extent of antibiotic use, the surgical operations they have had? All these are quite important. Nutrition and sepsis, very important, and we need to pay attention and treatment accordingly. And also we need to know when to stop. And it's important to have a dedicated team with you for these kind of intensive procedures. So, as I said to you, the type of procedures: anastomotic leaks, post-bariatric surgeries, iatrogenic perforations, Borhaus, trauma, and Zenker's ruptures. So the published data, as I told you, these are quite sparse. We've got about 28 publications from 2008 to 2014, but almost all of them are single digit. The patient recruitment is in single digit. And since then on, we've got some more publications which have come in. Again, similar indications, and range of sponge exchanges varies from 1 to 27, and exchange dates from 3 to 87. So success rate, almost about 100% in some series, but as low as 70. The mortality, not associated directly to the procedure, but along with the complications, is up to about 20% at the max. However, there are no RCTs in the group, there are no registries so far, and there are very few comparative studies. So the evidence of mortality regarding mortality is pretty good in comparing with stenting and surgery, as you can see, and also the success rate and the complications are favorable to EVT as well. So does it matter where you have the perforation, lower down, upper in the esophagus? No, really not. It's horrible to have this sponge right higher up into the upper esophagus for the patient, but the success rate is pretty good. What about the cost? So far, the reported literature suggests that the reoperation is the most expensive and can cause a very high morbidity and mortality to the patient, followed by EVT for the cost, and then self-expanding metal stents. However, the limitations of these studies are because they looked at the old cohort where all stent exchanges and stent insertions were done under general anesthesia, and almost more than 50% of the patient stay was in ICU. So that puts the EVT cost quite high. But in our study, we have only done cases under sedation, and there was no case done under general anesthesia. And it is quite important that if you have general anesthetic requirement for the patient, you need to think very carefully about your endoscopic resources as to how you can utilize, because twice a week sparing your GA list for a single case for about 8 to 12 to 16 weeks, God knows, it is quite labor intensive and quite an ask for the endoscopy unit. And also, almost all of these cases, the TPN was used for a significantly long period of time. But the new school of thought is once the sponge is in place and once the debridation has taken place, then you can start feeding orally in these patients. Again, complication rates are few. You have mucosal erosions, particularly when you place into the lumen rather than into the cavity. You've got stricture formation, sponge adhesions, fractures, if you leave it for more than 3 days. And then you have got bleeding. Bleeding is almost never a problem unless there is a significant bleed intracavity, wherein you have to use CT angiograms. Pseudomembranous colitis, I don't think it is directly related to the procedure itself, but related to the length of antibiotics used for treating sepsis in these patients. But there are no reported procedure-related deaths. The drawbacks of the procedure, again, tolerance for the patient. They need to be counseled for 3 insertions twice a week, and a procedure which can be quite brutal. So in conclusion, EVT is here to stay. It is first line of management in esophageal perforations in bigger centers already, and it is in suitable cases. You have to select cases quite carefully. Labor intensive, as I've said many times. Careful selection and counselling, pretty important. Optimizing the medical management, nutrition, and treating sepsis is quite important. Think about the impact on endoscopy service. Dr. Sood, my colleague and my friend, has set up a registry which you can contact him on that email address. And of course, there are more comparative studies needed, and more research work is needed in this field. Thank you very much.
Thank Thank you very much, Noor. I'm just going to ask a couple of questions we've hopefully got from our people who are watching online. I think the first thing to say is that it's obviously your understanding of what's going around the esophagus is really important, and how you relate to the negative sort of pressures that are there and how to treat those. But do you think that I think when you see a post anastomotic leak, do you think now we've got an established way of treating them with a sponge? Do you think there's a way of sort of now doing a trial where we delay treatment to see if something may heal up on its own, or whether the sponge, what time should we go for the intervention? You know, as you say, it's a big commitment once it starts. Yeah. So do you think there's now time for a trial or something to see?
It's a really good question, Andy. I think, yes, trial is quite important, but ethically, how do you convince a patient to wait and watch versus something which has proven benefit? Some of the patients, the surgeons will tell you that it's a small leak, it will heal on its own, conservative management. But for the larger ones, yeah, which have already formed cavity going into the pleural areas, those are never going to go on by their own. So endoscopic treatment is necessary. But you're right, there is nothing to guide us here as to which way to go. It's all experience and expertise, really.
Yeah, okay, thank you. And the second thing is as you said, we're alluding now to more enteral feeding to commence once the sponge is in place rather than TPN. Yeah. Is that right? Okay. Yeah. And do you think now we've got all these other things like stents and the over-the-scope clips and things, do you think it's worth combining these tools? Do you think they're eventually going to be a multimodal approach, or do you think the sponge is now the most effective way to such big holes? For
those small perforations, I think first line should still be endoscopic clip management. Yeah. Because we've got fantastic clips. Notes have given us a lot of different apparatus to play with. So I think we should make use of that. There is no reason why we need to extend the perforation and then put in a sponge into it to suction up the debris. But clean based perforation, you can close it with the clips. And yes, if there is a fear of contamination, or if there is a larger perforation which clips can't help, then first line is sponge.
Thank you. Okay. Thank you very much.
Thank you.
Okay, fantastic.